evaluation of left ventricular function by echocardiography. And we're going to try to do a little bit of discussion of imaging and imaging tips, addressing the problem of foreshortening, talk a little bit about dimension measurements is still commonly used for assessing size of the LV. Importantly, volumes and EF, which is the new standard that we should be doing more often. And then the new techniques like 3D and LV strain, and a little bit about regional function. So these are the four views that are most commonly used to assess LV function.
Something we do with every single echo that we read, and it's still one of the most common indications clinically for an echocardiogram. And when you have these kind of extremes, nice and normal on the left and real bad on the right, anybody can see that. So this one does not require a lot of training or skills to assess the fact that this is a really big ventricle with very poor contraction. However, you get somebody like this, nice quality image. Is that an EF of 60 or better? Is that a mid 50? Is that kind of a low 50s? Could that even be a little bit of high 40s? Those are the gray areas in estimation of EF. And actually, when you give courses and allow audience response systems, not uncommonly, you get something like this from the audience. When you project one of these cases where you have a gray area of EF, maybe mild, moderate, mild to moderate, or low normal. So estimation clearly requires a certain amount of expertise. And even the experts, like some of us do feel we are experts, still have to accept that it's a subjective evaluation. And therefore, if you're doing serial changes, it can be a little bit more tricky unless you have a very obvious change in EF. This document still is from 2015, the recommendations for a quantification by chamber sizes. And in that document, an important thing to remember, which is a big difference between echocardiography and CT and CMR. All three of them are tomographic, but to the echo, is not only tomographic, it has a very limited field of view. We don't see the whole chest. So we don't see how the heart is positioned within the chest. We're trying to cut the heart using a transducer in the chest, making different slices. And therefore, it's very subject to foreshortening. This is the same patient, only a few seconds apart. And you can see that in this EF, the LV looks small. And if we were to estimate, we might say, gee, I don't know, maybe low 50s, not too bad. Here, the transducer was placed better, less foreshortening. Now notice that the heart is a lot bigger, and clearly, that's a very depressed EF, big time wall motion abnormality in the inferior wall. So just a little readjustment of the transducer, and we suddenly have a dramatic change in EF. And we see this quite commonly, almost every day in the lab. So this is the Achilles tendon of this technique. And the problem is that you're doing a tomographic cut of the LV, and regardless of what view you are doing, you would like to be cutting that LV right at the center. Regardless of whether you're coming from a long axis view, short axis, apical, you want to be cutting this way. But if you cut slightly off that, then the heart gets smaller, and the same amount of movement of the wall now looks much better. Now, how do you know that you are in the right spot? That's for every sonographer doing an echo, that is the important question. Apical views, you're subject to not only that type of foreshortening that we saw in the previous slide, but another kind, which is not coming from the true apex of the LV, but coming from what looks like an apex. Maybe it's because you feel the apical impulse. It's been shown nicely many years ago that the apical impulse is not the apex of the LV. So if you feel the apical impulse and put the transducer there, yeah, you're going to get an image, but most likely you're going to be coming like this. And the way you know this, very easy, because when you go from 4-chamber to 2-chamber, the 2-chamber is tilted. And the apex is out here. This is a pseudo-apex created by the foreshortening. So you end up with a smaller heart, but can often look like it's contracting much better because once again, you are making that cavity smaller, and the same amount of movement of the walls make the appearance of being a better ejection fraction. And this is the worst, because this one has almost no solution other than paying attention to the short axis view. This is where the short axis view becomes critical. These are people that have significant translation, for example, after cardiac surgery. So in diastole, you may be perfectly in the center, but by systole, you're way off for shorten. And those are really tricky. And that's where having a good short axis is very helpful, because sometimes you may see in that short axis that the ejection fraction is depressed, and then you go to a fourth chamber, two chamber, and it look great because you were foreshortening. So again, this is the Achilles tendon, and in every case that you are doing an imaging, you have to keep that in mind and do everything possible to prevent it. And these are some of the recommendations to try to have the best image resolution and to avoid foreshortening. One of them that is very important, which right now we are having trouble with because we are doing so many echoes portable at the bedside of the patient, which really prevents doing this, which is in the echo lab, as you know, you have a nice cut hole in the mattress that allows you to go further down to the apical impulse, because the apical, the apex of the LV, because the apex of the LV is further posterior to the apical impulse. Now, this is a little more tricky to do when you are at the patient's bedside with their own bed and you don't have the convenience of having this mattress that is cut. So our portable studies are more subject to having foreshortening. So again, as readers in the lab, we have to be aware of that too. So most important point to bring when any measurements are going to be made: linear dimensions, cavity areas, volume assessment. Before you do any measurement, the first thing you do is you look at all the views. So it's very helpful to first look at a preview of all the views and get a sense, and then try to select those that to your eye appear to have the least foreshortening problem. Don't jump in and measure from the very first thing that you see, because that could be a foreshortened image. And the second important thing is use contrast whenever you're concerned that you are not getting the maximal enhancement in terms of the cavity size and contractions. So contrast, of course, is very, very helpful, and I'm proud to say that all of you are very much contrast-minded and you use it quite often. All right, so assessing left ventricular size, the ideal way is volumes, but we still do dimensions. So a couple of points on dimension. Number one, that although they were invented in the days of ENMOD, nowadays it's more accurate to measure dimension from 2D, because quite often we have angulated views in the parasternal position. Particularly if we have to go on a low parasternal to get a good image, the heart gets tilted. And if you were doing an ENMOD, the ENMOD would be doing a tangential cut, which would be increasing the size of that ventricle purely because of an error. So we make measurements directly from the 2D echo. We measure septal thickness, posterior wall, and LV. At end diastole, usually at the tips of the mitral valve. However, with dilated ventricles, cardiomyopathies, and so on, not uncommonly the ventricle becomes more spherical. And if you go a little bit further, you get a much bigger dimension. So I personally, when I'm dealing with big ventricles that are more spherical looking, move a little further to the middle to get that maximal dimension that will relate better to the volumes when volumes are done. The other thing that is very important is beware that for septal thickness, there is the moderator band here. And if you don't pay attention in real time before you pause the image, you may include that moderator band and end up with a septal thickness that is forcefully increased, then providing a diagnosis of hypertrophy that doesn't exist. Likewise, There are papillary muscles and chordae down here that is good to pay attention in real time so that when you stop the image, you don't include them in the posterior wall thickness. So those are little tricks that are very helpful so that you have a more accurate. And finally, pay attention to the thickness of both walls in the short axis views, because sometimes you may end up with thicknesses of 1.2, 1.3 when you were doing them in the parasternal, and then you go to the short axis and you see a very nice thin septum and posterior wall. That should make you go back to the parasternal and check for errors that could be coming from what I just mentioned. So the short axis view can also be very helpful. We all know that dimensions of the ventricle do relate to body size and gender. So even bigger ladies have smaller LV dimensions than bigger men. So we have these things in our lab, and we have these tables that we use with numbers and so on. So that's just looking at the references. We have them all in our lab, and we use them to assess whether it's enlarged or not, whether it's mild, moderate, or severe. But the best way to talk about LV size and function is with volumes. And if we're going to do measurements, then the method of disc is the preferred technique. And the important message that we have learned, actually, comparing echo volumes with CMR was very educational, because it taught us that at the beginning, we were doing too much foreshortening of the cavities because we were tracing too much inside what we thought was an endocardium, but frequently it's trabeculation. So we have learned now to be a little bit more liberal and go further back outside here when making some of these measurements, because they do relate better to the MRI standard. Once you make your tracings, what the computer does, it brings these two long axes and put them into a same value. If this one is bigger, then it enhances this one to be the same as that. And then it creates all these multiple discs and does the volume of each of these discs. So it takes this area here plus this area here, creates a volume for that slice, do volumes of all those slices and add them together. If you did this manually, it would take you one morning to do one case. Computers love this type of stuff. So they spit it out in no time at all. Okay. Now, one trick, if you don't have significant MR, is to compare that stroke volume that you get from your measurements with the stroke volume you get with the Doppler technique. And they both should be within 5 or 6 ml. So if you get 65 cc's in one and 70 on the other one, you're okay. But if you get 65 and 80 on another one, there's one of the two is not right, and that forces you to go back and kind of think through it and recheck things. And these are some of the tables that we have that tell us about what diameters are within normal range based on body size, male and female, correction for body surface area, and what is a normal, mild, moderate, severe. So those things are all in the lab, and we use them every day. Contrast really is helpful, because even when you have a nice quality image, because this is not really a terrible image, maybe a little bit of dropouts here. If you trace that, you get your volumes. In this case, we got an end-diastolic volume of 200 and an EF of 36. Okay, so yeah, it's a bad ventricle. It looks like a big ventricle. But look what happened when contrast was given. The ventricle became much bigger, 235, and the EF dropped. Okay, and this is what was observed many years ago in this study from the Mayo Clinic, where they did comparisons to CT for volumes, and this was without contrast. There was a correlation. However, tremendous underestimation of volumes by 2D. When contrast was given, the correlation was equally good or better, but more importantly, this dotted line is the line of identity. So you can see how close the regression line was to the line of identity. So that if you had a 250 cc by echo, you had around 250 cc by the CT. So contrast really brings us closer to correlating better with other standards today would be CMR. So we have 3D, and we are using it more and more often. And this was a very important study done years back. Important because it was a multi-center. They were using the initial older 3D technology, which was stitching several bits, like 5 bits together, and creating one image from those multiple bits. And again, nice correlation. And this was multi-centers, which was very important because there were more than one laboratory. So they had nice correlations. This is end-diastolic volume, end-systolic volumes, and EF, okay? However, notice that an end-diastolic volume by 3D of about 210 or 220 was over 300 by CMR. So again, struggling with that same problem of underestimation. So the ideal method, if we were going to do 3D today, would be 3D with contrast. And right now, that is still a challenge because the 3D technology gets in trouble when you have the contrast in the ventricle. There's one company that I'm aware of that is working around that. So if we could eventually do 3D with a contrast injection, that would really solve a lot of problems. But stay tuned because that is still have been somewhat challenging for the industry. Then we get to ejection fraction, and yes, there's a good correlation, but then you have these outliers. You know, in this particular patient, EF was 65 or 70, and 3D was like 20. I mean, that's like way off. This one is the other way. 3D is in the 55 to 60, and CMR was in the 40s. So this is why when we're using routine 3D, as we do every day, we still have to rely on the trained eye to look at those images, look at those values, and either accept them or reject them. So we still have not thrown away the eye because of the outliers. Yeah, so it's nice to have a good correlation, but when you have one of those outliers, if you don't pick it up with your eye and you report it 3D, you could be reporting a very wrong number. Now, currently, 3Ds are a heck of a lot better, mostly because the digital technology in the machines now have become extremely fast, capable of doing a lot of really elegant things with this auto-contouring algorithm. So now you can do 3D assessment of the LV, of the RV, of the LA, and not only do you get values, but you also can get even curves, like a volume curve for the 2D, because you can do a bit-by-bit assessment rather than having to average from several bits. So the new 3D technology is really cool, no question about it. And again, when you get good quality studies and good numbers, it's phenomenal. But I still rely on my eye to accept the value that is given me. And these are some data now with this type of newer technology where you can see a lot tighter relation of the EF with CMR. But this is real life. So just to emphasize what I just said, this is a very nice quality study, okay? I'm assuming everybody here is going to say that this EF is over 60. I would. Okay, so we do our measurement and we use the Simpson's rule technique, and we do all the tracing following the advice that I just went through it, excluding all these inside endocardial echoes. And we get an end-diastolic volume of 116 and a stroke volume of 77 and an EF of 66%. By Doppler, the stroke volume is 75. So we take it, what I agree, it looked like it was easily mid-60s. So we're happy, we're done, right? Well, this is the 3D assessment. EF 59, which is normal, but it's not the same as 66. And then look at the number, end-diastolic and systolic, stroke volume 30. This guy is almost dead. And we see that quite often, okay? So again, that's why we still, unfortunately, when we do 3D volumes, we still have to bring back the eye and sometimes do our own measurements because of these issues. That the technology, again, is still also affected by the same foreshortening issues that I presented at the very beginning of the talk. Now, there are many other cases that I could show you where there's very nice correlation between what the values you get from the 3D and what our eye agrees, and we take it and we report it. I've been reading echoes this morning and reported a bunch of EF by 3D. All right, so in summary, limitations of EF, first of all, we do have to accept with echo, we have a certain variability with transthoracic echo. Well done, without any problems. The new 3D technology probably are the most reproducible. There's some studies suggesting that may be true. And I think also when we use contrast, we tend to get closer also to having more accurate and reproducible methods. But at this time, we all agree that the gold standard is CMR, and we all try to do the best we can to get closer and closer and closer to CMR values. And I think we discussed some of the tips that we can do to achieve that. But importantly, EF is influenced by loading. Bigger preload, better EF. Low preload, low EF. If you don't fill the tank, preload is how much comes into the ventricle, how much blood returns to the left ventricle. So if you don't fill the tank, if you are having very low return, that EF is going to drop. Likewise, if you improve the end-diastolic volume, the EF. So within certain limits, EF is very preload dependent, directly preload dependent. But it's also inversely afterload dependent. So rapid increase in afterload, like somebody comes into the echo lab and have blood pressure 220 because they were very anxious, could affect the EF. So it's inversely affected by afterload, directly by preload. So a variety of heart conditions that have preserved EF have been shown to have myocardial dysfunction and poor outcomes, for example, HFpEF or chronic MR. So EF doesn't give us everything we need to predict clinical outcome in patients with a variety of diseases. And this is an old slide from a study in 2018, just emphasizing that point. Of course, once the EF goes way down, yeah, you tend to have higher mortality, but there's a range here between 35 and 65 or even 70 that you get all kinds of outcomes. And we see that every day in clinical practice. So that takes us now to strain. And strain is a product of digital technology. In fact, 3D, autoregulation, all of these things, beautiful things that we're doing today are a product of digital. So the image is in a digital matrix. And if you remember, digital matrix have a pixel, okay? The higher the resolution, the more pixels you have in the screen. So if you can take one pixel and follow the movement of that pixel through time, it went from here to here, okay? Then you can do the measurement in diastole and the measurement in systole between 2 pixels. So these 2 pixels were here, and then they ended up here. So now we can see that that distance shortened by x, which is a percent of y. So that percent shortening in different vectors is what we call strain, okay? And therefore, you could do circumferential strain because you're following the movement of a pixel around the circumference of the heart. You can do radial because you can follow that pixel as it moves inside towards the center of the heart from diastole to systole, and that radial strain is like a systolic thickening, okay? And then in the apical views, you can do the longitudinal strain, which is along the longitudinal aspect of the LV. And that's why, we have these 3 types of strains. But because a lot of studies showing that longitudinal strain has had a lot more value in detecting subclinical LV dysfunction and helping us in do a better prediction of outcomes. Right now, GLS, global longitudinal strain, is sort of the one that there's a lot more emphasis, a lot more publications compared to both radial and circumferential. So this would be a nice normal case, and this is longitudinal strain. And of course, what the computer does, it picks up certain regions of the heart, and within those regions, it calculates the shortening of those pixels and gives you a curve. So each of these curves are coming from one of those regions during the left ventricle, depending on the view. This is a fourth chamber, so it would be septal regions, apex, lateral regions, and so on. And then you get these nice curves, and then the average of that, okay, would be what we call average global longitudinal strain, and the peak of that in here would be the peak value. So that is then shown by having a bullseye. And a bullseye gives us the 17 segments using color to give us gradations of values, and then the system gives us average, peak, global, longitudinal strain with a negative value because it's getting smaller. So that's very nice, beautiful normal case. Here we have a bad cardiomyopathy, we have a lot of desynchrony, and we have some areas that are actually almost dyskinetic because they're moving the other way, some very hypokinetic, and some not so hypokinetic, and of course the average of all that is going to be reduced. So in this case, it's a minus 6.2%, okay? So the problem is that minus 6.2 is less negative than minus 22, okay? So actually, if the myocardium is bad, the strain is better, mathematically, because a minus 6 is higher than a minus 22. So that negative sign has really caused a lot of confusion in expressing this, all right? So a group of experts, including our own Dr. Zogby, got together in a nice room smoking good cigars, and they felt that this was creating confusion, and they recommended to eliminate the negative sign, but to then change the term. Instead of calling it global longitudinal strain, say shortening. Because shortening is a term that eliminates a sign, a negative or positive, okay? So by saying shortening, we can get rid of the sign. The nice thing for me is that global longitudinal strain is also GLS. It's the same abbreviation. Okay, and this is now part of the new guidelines. So, hot off the press, there's this document which I encourage everybody to go through it because it's very comprehensive on the clinical applications of strain echocardiography, a clinical consensus from the ASE and also European Association of Cardiovascular Imaging and European Society of Cardiology. And there was a big group that got in a room smoking cigars. I mean, these were a lot of names here of people who are quite experts and have done a lot of publications. It was shared by Jim Thomas, who likewise have had a lot of experience with strain. So this is hot off the press. And a couple of things that they first do is they talk about, okay, so first of all, the technology. It's not perfect. And there are times when the strain curves don't come out as good as we would like them to. So the document talks about what we should do, what to pay attention to try to decide whether the strain we are getting is properly measured, properly recorded, or should we throw it away. And then the second thing that they address is what is a normal strain or shortening. So one of the things that have been shown in large group studies of normal people, these are all normal volunteers, that as we age, there is a tendency for the GLS to drop a bit, okay? Also, that all kinds of different machines don't always give you the same value. So if you do the same patient in 2 or 3 different machines, as some of these investigators have done, you get variability. But the nice, interesting thing is that all these normal volunteers are always over 16, regardless of the age also. So what we have done in our lab, and many have done, is that 17 or better, we call it normal. Less than 16 is clearly reduced. But then this range here is called sort of a low normal, because actually there may be some clinical conditions where that low normal may not be so good. So this is where we are right now. The other important thing is, so obviously what strain can help us is with the detection of subclinical LV dysfunction in a lot of diseases. Give us a more objective assessment, because it's now we're removing a little bit the eye from the whole thing. And importantly, a prediction of outcomes, as we're going to review in a minute. And then there are regional patterns that are associated with myocardial diseases. So one of the nice things about this document, by the way, which is the first time I see this, very well done, that for every chapter, for every section that they have, at the end, they end up with kind of a summary, what they call it, the consensus by the group on that particular topic, okay? So this is taken verbatim from the document. Clinical advice for avoiding technical pitfalls in strain acquisition. They have a table too, which is immense, with even pictures going through every single issue that it's important to pay attention to. And then it's summarized here that there are pervasive technical pitfalls that can affect the accuracy of strain and are related to image quality, very important, image acquisition, region of interest selection, the algorithm-based tracking that can have errors, user definition of what is end diastole and end systole, extremes of blood pressure affecting loading conditions, and rhythms such as atrial fibrillation. One of the things that they pay attention, that they will discuss in the article is, depending on how the tracking is done, you could be tracking epicardial or subepicardial, you could be tracking more mid-wall, or you could be tracking endocardium. If you do epicardial, values are going to be much lower. If you do endocardial, values are going to be the highest, and mid-wall would be somewhere in between. So paying attention that your tracking is going more through the mid-wall, because that's the one that we're trying to do the most, is important. Some of the equipments, as you know, when you do the tracking, gives you like a band that covers the entire myocardium, and that might make it a little easier for you all to know that you are in the right spot. This was an important study that was done, which basically, both for fellows and sonographer, okay, it took somewhere between 26 to 50 studies to get values that were consistent, reproducible, and similar to what an expert person would get. So the training is not so horrible. It's not that you need to do 200 of these. But certainly, depending on the individuals, between 26 and 50 was sufficient. But by the time you went to higher numbers, you didn't gain that much more. All right, so let's talk a little bit about the clinical applications. This is where the fun starts. This patient has an ejection fraction of 90%. I mean, it's almost completely ejecting everything. You can see that he has a lot of hypertrophy, a lot of MAC, big left atrium, and he's clearly a young man with severe hypertension and end-stage renal failure. These are the classic patients that come in like this. But yet, despite an EF of 90% or whatever, the average peak GLS is 14.2%. And there's some regional values that are worse than others. Okay, you can see the curves here, very interesting. So it's a nice example of supernormal EF with a reduced global longitudinal shortening. And now there is an interest in looking at this in end-stage kidney patients that are awaiting transplant. And it could become a way to move them to a higher level of priority. In this small study, which is almost 300 patients on dialysis, that you can see that event-free survival was much better in the group that had a preserved strain. Those that were under 17, even in the 16 range, had a worsening of outcome over 5 years. So this is the beginning. Nephrologists are clearly now into this, paying attention, and this could potentially become one more parameter that could move up on the priority level of patients waiting for transplant. Whole list of diseases, you know all about this, where strain is abnormal despite adequate EF. And one of the first ones that got on the map were the chemotherapy toxicity, particularly ladies with breast cancer, so we're going to talk a little bit about that. And in every single condition, clinical outcomes are usually worse in those with a reduced strain. Now, the actual threshold of reduction of strain may vary a little bit between one condition and the other. So this is one of the early studies that was done for patients with breast cancer that were receiving cardiotoxic drugs. And it was observed that somewhere a reduction between 10 and 15% in peak average GLS appeared to predict an important reduction in EF during chemotherapy, but it was not 100% perfect. There was a lot of variability. So a little later, this randomized study was done with about 300 patients. They were all receiving cardiotoxic drugs, and then they were randomized. So one group was given cardioprotection, heart failure therapy, usually ACE inhibitors and or beta blockers, if the ejection fraction dropped over 10 points, okay? Relative points, not 10 absolute points. So a drop in EF was an indicator to start cardioprotection. The other group that was randomized was, we don't care about EF. If the GLS dropped over 12%, we will initiate cardioprotection. So if we look at the group that was treated based on the EF, even with cardioprotection, 2/3 of them continue to migrate to an EF less than 55%. They all started with obviously very good EF. Very good EF, okay? But if you look at the group that was treated with the GLS drop, okay, 61% remained normal, and only 39% went and continued to worsen their EF, suggesting that the GLS might be a little bit more sensitive and help make a decision. So again, you go back now to these strain guidelines, and at the end of discussion of that section, they give a little consensus, and basically they indicate that strains should be performed at baseline and throughout chemotherapy with cardiotoxic drugs to follow patients for cardiotoxicity. And in patients that have a relative decline of strain of more than 12%, it is reasonable to consider treatment with cardioprotective therapy, whatever the change in EF. So this is where we are today. Hopefully there'll be even more data accumulated. But it's nice to see now a group of experts sit down, review the entire literature, and come up with some recommendations. All right, so you've seen this before. Again, the theme is the same. There is a range of EF where the EF loses its power for predicting outcome, and strain might be better. And this was a classic paper. This paper is also featured in the guidelines. Over 4,000 patients, 5-year cause mortality, nothing else. Simple, straightforward counting bodies. They have both HFrEF and HFpEF, which because of that, it becomes very evident that the probability of death was very poorly predicted by EF. So this section here is mortality based on ejection fraction. In contrast, mortality based on global longitudinal strain or shortening shows very nicely that once you cross that 16%, you start dropping the GLS, very significant probability of death. Very significant. And again, remember, about half of this group were HFpEF. So there's a nice, good mix of HFrEF and HFpEF in this population. This is also an important study. Over 300 patients. These have HFrEF. These are the cardiomyopathies, dilated cardiomyopathies with a low EF, but they were in optimal therapy. So they were class 2. They were happy taking their pills. Okay? So they were in what was considered optimal medical management. Okay? 66% were men, and they were all, again, guidelines, optimal following guidelines. So this is 10 years. Okay? So, best group, EF greater than 40 with a GLS over 13. They had a wonderful course for 10 years. Worst group, EF less than 40, GLS less than 13. But the interesting thing is that the group that had an EF less than 40 with a better GLS was equal in survival to the group with a better EF but a lower GLS. So again, GLS appeared to be the indicator rather than the EF in this particular group here. So a very, very important study also. And this is the kind of data that it will eventually impact the clinical guidelines that we're all going to see in the management of these diseases. Now, aortic stenosis. It's already been shown that with severe aortic stenosis, a GLS under 16 increases the likelihood of symptom developments within a few years, need for AVR, and so on. So already in our follow-up of people with severe critical AS who are asymptomatic, we all are paying attention to the GLS as well as we're also paying attention to troponins and to BMP and so on. But this is even more interesting because this is the group that we still are all scratching our head with, moderate aortic stenosis. What do we do with them? So this study, they entered 760 patients. They all had a valve area of 1 to 1.5. Peak velocity across the aortic valve, less than 4. So they were just the typical ones that we see every day in the lab. 3.2, 3.3, mean gradients in the 20s. Valve area 1.2, 1.3, okay, 1. They were followed up for 50 months. So median follow-up, I'm sorry. These are 72 months. These are median follow-up of 50 months. Again, one single endpoint, mortality. That's all. And here you see GLS, EF over 50%, GLS greater than 16, EF less than 50%, or EF greater than 50%, but GLS than 16, the same curve with a drop to almost 40% of them lost in 5 years. And this makes it even more interesting. This is the subgroup in this study that were asymptomatic at the beginning of the study. So these are asymptomatic patients. They all had an EF over 50% upon entry. And again, here you have your GLS indicating the prognosis for survival over 5 years. And this is the hazard ratio. Again, once you cross that 16 mark, very significant increase in the hazard ratio. Mitral regurg. An earlier paper that I think I have shown in previous conferences have shown that in mitral regurg, just as you want to see a high EF, you want to see a relatively high GLS. So the marker for trouble in MR, and we're talking about primary MR, of course, not functional MR, is 21. So a GLS less than 21 was an indicator for more symptoms, more trouble in patients with primary MR. In this study, they look at follow-up through surgery and post-surgery. So this is pre-op, immediately post-op, and usually about a year or so after surgery. Everybody drops their EF after surgery, and they drop their GLS. So these people had GLS greater than 18. They did drop. These are the EF, by the way. These are EF. So they start with very good EF. They drop to EF in the low 50s, and 1 year later they recover. Okay? But the group that had a GLS then lower than 18, first of all, starts with a little lower EF, low normal, drops a lot more, and then recover, but still not quite. Doesn't even make it to 50. Now, of course, these are average values, and sure, within that, there's going to be variability. But again, making the point that the GLS importantly predicts post-valve surgery ejection fraction. And this is more important. This is, I think, the same author, Kim. These are cardiac events and all-cause death. So these are all the typical cardiac events, death plus heart failure, hospitalization for heart failure, and this is just simple death. And again, these are following patients up to almost close to 5 years. Look at the difference in cardiac events post-surgery. This is post-surgery, okay? With 18 being the marker between normal GLS or reduced GLS. And the same thing for death, okay? Then this is a more recent study that what they have done is they have followed through 30 months the behavior of GLS in patients depending on the severity of mitral regurg. So those with mild MR, okay, they drop a little bit. Again, these are average values, so you're going to always have variability between patients, but these are, as a group, going from 22 down to 21, okay, over 30 months. Still staying in a relatively normal range. With patients with moderate MR, they start at almost 20, but they end up now at 17 in 30 months. And severe MR, a course almost similar, but even worse. So this is the first paper to do a time course of GLS in MR based on severity, okay? This could definitely have eventually an impact on clinical decision in terms of how much to wait when you have this potential for dropping to levels that we know once you hit these levels, we have the other previous studies showing that the post-operative course is not as good. And then this is with CMR, just to show that another technology have very similar findings. So these are the Kaplan-Meier curve for survival free of a composite outcome, mitral surgery referral and cardiovascular death in MR based on GLS. And again, showing that the lower the GLS, the more and more events happening in these patients. So different technology, CMR, which can also do strain measurements, findings that are very similar. Now, this is patients with sepsis, and we see this. Quite often we get these portable from the ICU stat, patients are doing very poorly, they have sepsis, and even the EF may be dropped. And then if they survive, we see the EF come back and improve. So this was a group of investigators that were interested in seeing whether strain or GLS could also give us a prognosis in these patients. And lo and behold, they used 17% was the marker. And this is the survival, again, this is just straightforward survival of the group that had preserved GLS, 17 or better, versus the group with a depressed GLS, all right? And this is days. This is not months, no, this is days, because these are critically sick people. And you can see that within a month's time, a very significant, in fact, the two curves start to separate close to 2 weeks. So very significant prognosticator for what may happen to patients that are acutely ill with sepsis. So what about regional function? Well, before we show cases, two important things. In that same guideline document, they reviewed the literature in studies that have done reproducibility and accuracy of the regional measurements. And regional measurements have a lot more noise than global measurements. So for regional measurements, the absolute values, you can have all kinds of noise depending on machines, day to day and whatnot. However, the patterns that you see, particularly in a bullseye, tends to become more consistent. So for regional, we don't look at numbers, we kind of overall look at a pattern. So everybody in this room will recognize this, otherwise you are excused. Patient that has a big infarct, inferior wall, inferolateral wall, and even a little bit of lateral wall right here, okay? And the bullseye shows very nicely the areas that are preserved and big areas within that, either dominant right or dominant left, that are affected. In addition, you can see this curve here. This is end systole. After systole, there's a little further drop in the strain curve. Keep that in mind. Now, this is somebody that by 2D looks like maybe the apex is down a little bit. But the strain confirms it very nicely by having this real area here of very poor motion. This case is even more interesting because this patient basically had an EKG with questionable MI because of poor airway progression, but we see that quite often also as a false positive. So is this real or not? So here's the 2D echo. Very hard to say anything about this, okay? However, the strain clearly showed an area here of very, very bad reduced numbers, okay? So next thing would be shape up your contrast. And there it is. Very nice apical akinetic area. So clearly there are patterns in the GLS bullseye that can point towards potential for ischemic abnormalities. So this is from the guidelines document. And an observation that they reported was that when you look at a strain curve coming from the region that is abnormal, frequently it has, after end systole, a further drop. In other words, the segment actually starts to shorten a little more. Because remember, as you go down this way, you're shortening. So this is shortening, that's lengthening. So it was shortening poorly, and systole comes in, and bingo, it has that little extra notch. They showed the angiogram just to show the subtotal stenosis. And this is a pattern that has been reported in infarcts. So again, you don't care about the absolute value, but the pattern apparently has been observed as being fairly reproducible in the region of ischemia, where you may have this very early post-systolic further shortening, and lo and behold, we have been talking about this for decades, something called post-systolic accentuation in patients in an ischemic myocardium that is still not totally dead. So this is more of an acute finding in the early hours of an infarct. Kind of acute, interesting observation. We all know the story with amyloid. It's not pathognomonic, but it certainly points out to the possibility of amyloid where the apical segments contract, shorten better, and therefore you have this apical sparring bullseye. And this is somebody that has what looks like a great heart, great looking heart, but again have this apical area. So could this be another ischemic myocardium? Maybe. But when contrast is given, clearly what this is an HCM patient with the apical variance where you have obstruction of the apex with this cavity here with very high pressures and in fact a little bit of an apical infarct. And the strain picked it up very nicely. And this is one of our patients but this is from the guidelines document. So in the guidelines document, they have these different bullseye patterns in other type of cardiomyopathies, okay? So this is a regular ACM. We have a lot of septal abnormalities. This is the apical variance, like our case that I just showed you. This is apical ACM with an apical aneurysm, where you have this blue area because it's really dyskinetic. This is your typical amyloid. This is end-stage renal disease, frequently has just more of a diffusing abnormality. And this is a Takotsubo, as you would expect, more the distal segments abnormal with the base being more preserved. So again, these are all patterns that may not be absolute, but certainly can be helpful when you are going through a case. Particularly, this one I like because apical ACM without contrast can be missed quite easily by 2D echo. So doing a strain and seeing that abnormality should be an immediate trigger for injecting contrast because that might then bring it up very nicely. So in summary, without question, strain or longitudinal shortening, whichever of the two terms you prefer, is an index of myocardial fiber shortening and thus a better marker of myocardial function. I think that the data is very strong on that. GLS provides a better prediction of cardiovascular events and mortality than EF in patients with a variety of conditions, heart failure, valvular lesions, cardiomyopathy, sepsis, and future treatment guidelines are likely to apply this data to make recommendations in management. Regional strain may help in detection of regional abnormalities in ischemic heart disease, but also in selected type of cardiomyopathies. Now, the things we have to pay attention to and be careful. First of all, as we mentioned at the beginning, the strain that we're getting may not be accurate. So quality of image acquisition, foreshortening, all these things that affect regular 2D can affect strain, and today still with most machines, we cannot use contrast. Strain is also influenced by changes in loading conditions, so it's good to always have a blood pressure around to consider when reporting it. Inaccurate results may be incorrectly accepted, and that's the one that worries us the most. How does one know that an abnormal result in a patient that had completely normal echo otherwise is really abnormal? That's when I really think twice before reporting it, because you have a perfectly beautiful echo, EF is normal, nothing is enlarged, diastolic function is normal, everything is cool, and then you get a value of 14.7. Do we report it, or do we rather keep it back? That's a case-by-case decision we all have to make. And then, how do we treat asymptomatic patients that have normal EF but abnormal global or regional strains in different conditions? In other words, what's different between an HFpEF with a low strain and a HFpEF with a preserved strain? Are we going to make any dramatic changes from here on? In the guidelines, they talk about the different grades of heart failure. As you know, grade A is when people are at risk, but they still don't have any major changes. Grade B is when you already see some changes, LVH, big left atrium, diastolic dysfunction. So what if you are in the grade A, but you have reduced GLS? Should that then convert you to a grade B? So those are the kind of things that the heart failure guys are going to have to talk around in their own smoking cigar rooms and make their own decisions. Is it time to start recommending therapy that we would normally do for a group B in a group A that only has a reduced GLS, okay? And the same thing for many of the other conditions. We talk about aortic stenosis, moderate AS, and so on. So we will have to start building guidelines and recommendations, because if not, why bother measuring, right? It has to be something that ends up in helping us take better care of our patients. And with that, I'm going to stop and take some questions. Thank you. There's some mics here, if you guys want to. If not, just loud, say it, and I will repeat it.
Do we have strains that, like, as people age, the strain values change and the cutoffs change?
Yeah, so the question is, does GLS is affected by age? The answer is yes. I just show you a nice slide with it. Soft, slight reduction in age, okay? However, despite that, 16 appears to still be the marker because no one old but healthy dropped under 16. So that's why the 16 has become kind of, but again, with the proviso that in some conditions, like mitral regurg, for example, this 16 might be too low. So as long as we remember that overall, 16 is kind of the marker. Yeah. Any other questions?
I have a question. So for valvular heart disease, it seems like there's a lot of studies that they did, and GLS is, predicting the outcomes better than the EF. So since this is the case, why they're still using EF? I mean, the studies were done early on.
So the question is, why are we still using EF? And it's a great question. And maybe one day we will stop using EF. The problem is, EF is 60 years old, millions of papers, lots of clinical decisions based on it. So it will take some time. Yeah, it will take some time. Now, no one wants to have an EF of 20, right? But even with an EF of 20, based on what we have seen today, if you have an EF of 25, but your GLS is 13.2, and another patient with same EF has a GLS of 9, that second patient is going to have a much worse outcome based on the data that has been shown. So GLS even modulates the outcome in patients with bad EF. Now, in good EF, forget it. EF is worthless. So in people with HFrEF, GLS is really the only good marker. And diastolic function. I think that's been shown also that, grades of diastolic dysfunction are markers. So if you combine grades of diastolic dysfunction with GLS in HFpEF, you could have a very nice algorithm for very high-risk patients. Problem is, do we have any special therapy for them that we would do different from the other type of HFpEF patient? For HFrEF, however, it could be an indicator to put a patient at a higher level for transplant. You have a patient with 26% EF, class 2, but a GLS of 7. Maybe that patient should be thought of a little bit more critically sick and perhaps move closer to a transplant if otherwise the patient is a candidate. So these type of things will have to be, evolve with guidelines and as people get more data.
And then one last question that I'd like to ask. So since GLS is it seems like, based on my understanding, it drops before even EF drops. There were some tables where the patient has EF less than 40, but GLS remained high. There were two groups of patients, EF less than 40 in both of them, but in one of them the GLS was more than 40.
Higher than the threshold.
Correct.
Not normal.
So yeah.
Yeah, higher than the threshold. So for example, for the cardiomyopathy study, these were AC. So the question that was being asked for those who are out in their computer at lunch, is that in some cases the EF was down, but the GLS was high. But it's not high; it was higher than the threshold. So for cardiomyopathy study, it was 13%. So patients that had EF, let's say, of low 40s or under 40, but had greater than 13%, had a better outcome. But they were not 17, 18, or 19. Yeah, they were higher than the threshold that they had found that divided the two groups. Eventually, basically, what you do is you do these studies, you do the measurements, you follow people. You throw everything to a computer, and then you do the statistical analysis, and the statistical analysis itself gives you that threshold. It's not something that you sit down and say, this one looks nice, let's use it. No. It's done by doing statistical analysis, and then that threshold comes out as the best divider between the better outcome and the lower outcome. In that particular study, it was like 13%. But for each disease entity, that threshold could be a little different. Like for mitral regurg, it's more like 18%. For aortic stenosis, it appears to be 16%. Yeah.
Is there anything that people can do behaviorally that would improve heart's shortening capacity?
So the question is there anything that we can do to improve the shortening of the myocardium? And the answer is we have no idea. Sure, if you have hypertension and you have LVH, you want to treat your blood pressure. So I mean, clinically, yeah,